Shoot, I'm late. All right, let's begin. So I have two announcements. I didn't make an announcement slide, sorry. Two announcements are, one, we have a homework assignment due Monday. And then two is I also want to do IDEA course evals on Monday, so please bring your laptops. I think most people bring them around anyway, but please bring your laptops so you can do those at start of class on Monday. Aside from that, I don't have anything else. You guys have any questions before we dig in? Goal for today is we're going to do schizophrenia. So, and talk that out, and that'll finish off this chapter. And I don't know. Well, I don't want to promise we'll get out early. We might not. Depends on how elaborate I get. So, we have already talked about anxiety disorders. We've talked about affective disorders. And both of those disorders have some common themes to them, some common mechanisms, both involving HPA axis, for example. Serotonin may be involved in both on some level. The last one, or the thing about them I think is kind of interesting, is that anxiety and affective disorders, in a way you can think of them as just like more extreme versions of normal mental processes. Like we all get anxious at times. Like everybody has anxiety about something occasionally. And everybody gets into a bad mood or a sort of a sad or depressed mood. They just don't necessarily rise to what we would consider to be, clinically generalized anxiety disorder or major depressive disorder. They're not on that level necessarily, but everybody sort of experienced something. So we have some feeling for what it might be like to have a more extreme version of those feelings, right? Schizophrenia is not like that. Schizophrenia is where you have, it's defined here as a loss of contact with reality, disruption of thought, perception, mood, movement. This first bit, like loss of contact with reality, so here we really are starting to encounter individuals that are experiencing things that most people have not really experienced. And so it's difficult for us to empathize and relate in quite the same way that one might with an anxiety disorder or an affective disorder. Schizophrenia is characterized by having both positive and negative symptoms, and this is always confusing, I think, when you're first encountering this, because it sounds like positive symptoms would be good things and negative symptoms would be bad things, and that is not what these terms are meant to indicate at this time. Positive symptoms would be presence of unusual things, so whereas negative symptoms would be like absence of usual things. So they're not meant to indicate that one is good or bad. It's positive means there's something there that isn't usually there. Negative means there's something missing that isn't normally there. So positive symptoms for individuals with schizophrenia can include delusions, hallucinations, disorganized speech, disorganized or catatonic behavior. So we have, the person's experiencing things like with hallucinations, for example, or delusions, that aren't really there or aren't a matchup to what is going on in reality. So those are positive symptoms, things that are there that shouldn't be. Negative symptoms, on the other hand, would be the absence of usual. And so these include things like reduced expression of emotion. So they're not expressing emotions as they normally would be. It's like emotions are effectively missing, and therefore that's considered a negative symptom. A poverty of speech. So they're unable to speak, or they have a diminished speech capacity. Difficulty initiating goal-directed behavior, so they have a hard time initiating actions effectively. They have memory impairment, so these are negative symptoms because these are things that are basically missing that normally would be there. Okay. So what's going on with schizophrenia? What's causing this disorder? Because it is such an unusual, it is getting into things that seem to span out of the range of what we typically experience. There does seem to be a fairly strong genetic basis in that there are genes that are involved in, the genes that have been identified to sometimes be involved. And it's not like there's a gene for schizophrenia, but when they do genetic studies looking at families and they see some heritability component to it, and if they see some of the genes that are particularly loaded and related when they do these sort of large association studies, they find that the genes that are involved tend to involve or affect synaptic transmission or plasticity or growth of synapses or growth of neurons. But it's not like there's this complete penetrance. So even identical twins don't always both have schizophrenia. So while there's a heritable component to it, even if you have a particular genotype, you are not guaranteed to develop schizophrenia. But again, there is a substantial heritable component to it. So, and you can see that here with this figure. So what this figure is doing is basically just plotting people as you go from the top of the y-axis to the bottom of the y-axis. You're going from people that are basically unrelated, and so we're looking at the percentage of typical genes that vary within human populations. How many of those are you sharing? And so amongst those genes that do vary, the general population, well, I should say the x-axis here is lifetime risk of developing schizophrenia. So if you compare a person to any other random person from the general population, there might be a 1% commonality in the likelihood that both of those individuals would have schizophrenia. So that's, this is sort of our low point. But as you increase the relatedness of those individuals, you see an increased likelihood that both would have schizophrenia. I guess really the way this is showing is what this is really asking is it's saying, all right, so if this person has schizophrenia, what's the likelihood that this other person will also have it? So if you start with, this person that your focal individual has schizophrenia, if you compare to a general population, what's the likelihood that other person in the population will have it at least at some point in their lives? It's 1%. But if those two individuals are first cousins, you actually double that, and you're now more likely. So these guys have 17% or so of their genes shared if you're a first cousin with somebody. So sometimes they'll call that a third-degree relative, because it's not dealing with your sibling, it's dealing with your siblings, and not even your siblings' children. It's well, you know what a cousin is. I don't have to actually explain that. In any case, so cousins or aunts and uncles, so these are low relatedness, but as you become more related, you see a gradual increase in the likelihood that if one person has schizophrenia, the other person will also experience schizophrenia at some point in their lives. So this includes, again, uncles, aunts, nieces, nephews, grandchildren, so half siblings. So here we're getting to be much more closely related. We're talking about a grandparent versus a grandchild. And then here we are dealing with first-degree relatives. So this is basically parent-offspring, or this is siblings. So here is if you have schizophrenia, your parents are 6% likely to have it. I think it's kind of interesting. If a parent has it, the children are 13% likely to have it. I don't know why those aren't quite the same, but it probably speaks to some environmental influence. Siblings are shown here at 9%. Fraternal twins would be siblings, but they're twins. They're not identical twins. They're fraternal twins, but they tend to have a more common environment. They certainly shared the same uterus, for example, at the same time. And then, they're going through life in much the same way if they're twins. And so they tend to have a higher environmental similarities than even standard siblings. And that might be the cause of this increase in relatedness. Identical twins, though, are shown here. So here is you have the exact same genotype. And then we're seeing that if one identical twin has schizophrenia, there's almost a 50% chance the other person will. But the flip side of that is there's only a 50% chance. There's also a 50% chance they won't have that. They won't develop that mental disorder. This shows you something about there are some substantial changes that occur within the brain of the person that's experiencing schizophrenia. So one thing that's fairly typical is an enlargement in ventricles. So these are MRI images, and what you can see here is that the ventricles in a schizophrenic twin tend to be pretty large. Here is a normal twin, so this is this person's twin, but this person does not have schizophrenia, and you don't see that same enlargement in ventricles. I think it's pretty clear. These are almost twice as large, probably in terms of volume. So definitely a heritable component. Yeah, sorry. That's a really good question. Yeah, so I think the idea is there are certain genes that lead you to have increased likelihoods depending on what environmental influences you get. It's probably the case that the genes that are involved, though, are pretty common, or the alleles that are involved are pretty common, such that probably many of us have some of them. And it's a matter of how many of them do you end up with, and then what environmental conditions do you end up with that causes it. So probably you need to have some genetic predisposition, but probably most people have some genetic predisposition, I guess is what I would say. Yeah, so definitely seems like there's some kind of a heritable component to this whole disorder. In terms of what environmental factors might be the things that might drive you to express the phenotype, if you have the genotypes that might lead to it, there's certainly no one thing, but these are things that have been shown to at least be risk factors. So if you, sometimes people, well, there have been studies that have shown that when there are viral infections that an individual experiences as either a fetus or an infant, that can increase the likelihood that you're going to express schizophrenia. None of these things are determinate, but it can increase your likelihood of expressing schizophrenia. If you have poor maternal nutrition, if you have marijuana use in an individual, and frankly, there's a bunch of other factors that have been implicated as well, where there are, these are things that we found that are present in the environment of the person, effectively, changes in how the environment interacts with their genes that then may have, at least has some sort of correlation to development of schizophrenia. But again, mechanism isn't known in any of these cases. So what is the mechanism? Maybe we don't know exactly the basic cause, but what is the, what happens in the person is sort of the next question. But I saw your hand, sorry. Yeah. That's a great question. Yeah, so what is age? And it's a little bit of both, right? So, so in terms of how is age somehow genetic, there are genes that get turned on and turned off at different points in our development routinely. And so when certain genes, so puberty, for example, is the time, and then some years post-puberty is the time when a lot of people do start to express schizophrenia. So it could be that there are genes that are turned on when one hits puberty that tend to increase your likelihood. So in that way, maybe there's a genetic component, but certainly age also has a major environmental component because you're being exposed to more and more things over time. So the answer is, I guess, a little bit of both. But yeah, that's a good question. Okay, so maybe we don't know what initiates schizophrenia to happen in a person, at least not specifically for any one patient. We have some ideas of things that can increase your risk factors for them. But what exactly is happening within the mind of the person? And one of the ways that, that we can start to hone in on this, kind of like we did when we were talking about some of the other disorders, like affective disorders, is we can look at drug use. And in this case, the stuff that was, the drugs that were most influential or most helpful in terms of understanding what's going on with the schizophrenic patient were recreational drugs, as opposed to, in the other case, it was more pharmaceuticals that were used to treat disorders like blood pressure disorders when we're talking affective disorders. For example, amphetamines, so this is speed or other similar kinds of stimulants, do tend to cause an increase in dopamine release. And if it's certainly been found that individuals that have very high amphetamine use can sometimes lead to psychotic episodes where they have some of the symptomology that a schizophrenic patient might experience, especially some of the positive symptoms, like things that aren't there. So they're hallucinating or they're getting delusions as a result of high amphetamine usage. And perhaps the mechanism might be common there, where schizophrenic patients might have increased dopamine release. And that's supported, again, by this fact that if you give somebody amphetamines and that causes them to have elevated dopamine release, you can sometimes mimic some of the symptoms of schizophrenia. There's other drugs, these are called neuroleptic drugs, that are sometimes used to try to treat schizophrenia. And it seems to be what they are typically doing is they're combating or they're doing something with dopamine. So again, dopamine sort of lighting up here. So these drugs that are used to treat schizophrenia, neuroleptic drugs, one of the things that they will often do is they'll block one of the dopamine receptors. A lot of these types of neurotransmitters have multiple kinds of receptors. This one happens to be called the D2 receptor, so dopamine 2 receptor. And there's actually a whole suite of these drugs, these neuroleptic drugs, that do block the dopamine receptor. And they vary in terms of how tightly or strongly they interact or bind to that dopamine receptor. And that the degree to which they have an affinity for dopamine, excuse me, affects the dosage you have to give them then to treat schizophrenia. So that's what's shown over here on this picture, or this graph. So what this is shown here is the average clinical dose of whatever the pharmaceutical is. And each of these little dots is a different pharmaceutical, and you can see all their names that are listed up here. Some of these drugs, as you can see over here, require very high doses per day. So here we're talking about 1,000 milligrams per day up here in order to treat the neuroleptic condition, or to treat the symptoms of a schizophrenic patient. Whereas over here on the smaller side of the axis, these are much lower doses. So these are effectively, because they require lower doses, these would be more potent medications, right? What this is showing on the y-axis is the affinity of each of these drugs for the D2 receptor. And it's a little bit, the way it's measured, the way affinity is measured, it results in kind of like a backwards axis from my sort of simplistic point of view. So this is a quantitative measure, but basically what this is showing is that down here this represents high affinity for the dopamine 2 receptor, whereas up here is low affinity for the dopamine receptor. So up here these drugs don't bind very tightly to the receptor, whereas these guys do bind very tightly to the receptor. So yeah, go ahead. Let me come back to that one if I can. So what this, I'm not trying to say, it's just I want to focus on the positive ones right now. So what this graph shows, right, is that as you start to deal with drugs that have lower and lower affinity for the D2 receptor, that's going up this way, you start to have to give higher and higher doses of them in order to cause some kind of a change in the person. Which makes sense, right? But this is certainly indicating that it really is, it's the D2 receptor affinity of these drugs rather than some other potential effect that they have that's driving their ability to modulate schizophrenia in these people. So if these guys are basically in charge of blocking dopamine receptors, this one's spitperone is extremely high affinity for the D2 receptor, and therefore you need to give barely any of it because it's just such a good drug to bind to that receptor. Whereas again, this one, promazine, has a pretty low affinity for the receptor. It still binds to it, but just not very strongly, and therefore you have to give a ton of this stuff in order to cause the same kind of a change in the patient. Okay, so it's indicating that there's something about the dopamine receptor that is driving the behavior of schizophrenia, or driving the condition of schizophrenia. And furthermore, there's another nice commonality that if you use these same drugs, these neuroleptic drugs that we use to treat schizophrenia, you can also treat or shut down amphetamine-driven psychoses. Right? So the psychoses that a drug addict that's high on speed might be experiencing, you can basically block those by giving these same drugs that are used to treat schizophrenia. And again, the argument here is that it's because it's all related to dopamine. So dopamine seems to have, high dopamines anyways, seems to be pretty tightly related, or at least there's really good evidence that it's related to the positive symptoms of schizophrenia. But wait, there's more. It's not all schizophrenia, or not all dopamine when it comes to schizophrenia. There's another hypothesis that is also well supported in the literature, and it's the glutamate hypothesis. So this is, I'll sort of run through evidence based on this. So some drugs that are out there, some recreational drugs, interact, instead of being involved or related to dopamine, they seem to be somehow related to glutamate. And glutamate is this sort of widespread stimulatory, excitatory neurotransmitter. That's the word I'm searching for. That's found throughout and used throughout our nervous system. We've talked about it all sorts of times. You know, we talked about it in pain pathways and other kinds of pathways as we're working through our semester here. Several of the recreational drugs that are used, so these include PCP, which I guess is sometimes called angel dust. I'm not down with the street lingo as well as maybe I should. And there's ketamine, which is an anesthetic. In fact, we used ketamine, we talked about ketamine in the sleep chapter because it was used to anesthetize mice. But that is special K. So these guys also can induce some of the symptoms of schizophrenia. But neither of these seem to be working through dopamine. Instead, they seem to be doing something related to glutamate receptors. So both of them can bind to and inhibit NMDA glutamate receptors. Glutamate, kind of like we saw with acetylcholine, there's several different kinds of receptors that can bind glutamate. One of the most common is NMDA receptors. And so what ends up happening is what's depicted here. So here's an NMDA glutamate receptor, and you can see it does function as a channel. But within the glutamate receptor, there's a PCP binding site. So there's this location where this molecule PCP, angel dust, can actually bind to. And so what will normally happen is that glutamate could come down. It could bind to its receptor, which opens this channel and allows sodium ions to start rushing in, exciting the cell. But if you expose them to PCP, PCP can basically slide in and then kind of get jammed up in here and block the channel. So in this way, these two drugs seem to block glutamate transmission, and they do seem to initiate some of the symptoms of schizophrenia. So for example, if you treat mice, or if you cause mice to have reduced NMDA receptors, so we're sort of directly, these are more transgenic mice where we've manipulated how many NMDA receptors they have, they'll show reduced social behaviors. So you can see that down here. So here is, this is like normal mice behavior. They tend to huddle when they sleep. They're pretty social animals. But these guys have reduced numbers of NMDA glutamate receptors, and they tend to not huddle as much. And so they're showing changes in effectively like a withdrawal of normal social behavior as a result of the loss of this glutamate transmission. And this loss of glutamate transmission sometimes is treatable with some of those neuroleptic drugs, which is kind of interesting because we're saying this is a glutamate-based response, and yet the neuroleptic drugs were involved and related to dopamine. So we've got some sort of intermingling between glutamate and dopamine. This is definitely an area of ongoing research, though. So it's not, I don't think there's, full understanding of all the pathophysiology, the mechanisms that underlie schizophrenia, but certainly there's something going on with dopamine, and there's something going on with glutamate in many, if not most of the cases, based on studies like these that are coming out. Well, they clearly are very tightly associated with dopamine, and that's what this is showing. But they seem to have some effect on these mice, which we manipulated their glutamate transmission. I don't know what the mechanism there is, but there's some sort of connection with glutamate as well, therefore, I think is the argument. So, I guess the shorthand is it's glutamate, it's dopamine, and some intermingling of the two that's leading to schizophrenia. Yeah. That's a very good question. I don't remember. I just know that this is a glutamate receptor. It's one of the 3 major varieties. I think we skipped that. But if you go back to chapter 6, the same area where it's talking about acetylcholine receptors and the muscarinic versus nicotinic receptors, there's also another figure on the same page that shows 3 different kinds of glutamate receptors. And one of them is NMDA, but I don't remember what it stands for. It's probably the most common, at least it's the type of glutamate receptor I see most often talked about and discussed in literature. Anybody happen to know? I'll show off. I don't know either. Okay, so maybe we don't know exactly what it does, but we do know some of the things that it does. So treatments for schizophrenia, one of the things that we've just talked about is the fact that we do have all these neuroleptic drugs that do seem to attack and inhibit the D2 receptor. So if the argument is that a schizophrenic patient may have too much dopamine present within their system, then if you're able to block that receptor, you can therefore reduce the amount of dopamine neurotransmission that's happening, because you're basically, even though that dopamine's still there, you are basically blocking and preventing it from having much of an effect. And so neuroleptic drugs, like were shown on that graph, and these include this one, chlorpromazine, these directly do bind to and inhibit and block that D2 receptor. And so that's what's being demonstrated here. There's a lot of work on additional, the problem with these, as we sort of mentioned, is these tend to be really good at inhibiting the positive, or well, better at inhibiting or reducing the positive symptoms of schizophrenia, but not so much the negative symptoms of schizophrenia. So there's certainly efforts to find additional targets for additional pharmaceuticals that can work to help people with schizophrenia. One of the targets that is getting a lot of research is looking at drugs that directly interact with the NMDA receptors, so that if something's going on that's impairing glutamate function and glutamate neurotransmission, kind of like is induced when you give somebody PCP, like we saw in the prior slide, if we can somehow prevent that from happening, that could therefore hopefully alleviate some of the symptomology that a person is encountering. Kind of anticlimactic. I don't feel like I have a great answer, but it's not. But that's because there is not really a great answer right now on schizophrenia. So that's more or less the chapter. I just kind of wanted to finish with this note that I think one of the real positive things that has happened over the past, I don't know, like 20 years, and then it's really, I think, even continuing to gain momentum over the past several years, is I think there's increasing recognition that mental illness is a result of pathological modifications within the brain. It's not just something that someone sort of decides to be or makes some decision to have some sort of mental disorder. That you have some sort of pathological problem either with neurotransmission or structure within the brain. And so treatments tend to be focused on restoring normal brain function, and that can be done both through pharmaceuticals as well as through talk therapy, psychotherapy. Afflicted individuals are more and more, I think, treated as patients as opposed to criminals, which was not the case 100 years ago. 100 plus years ago, if you're exhibiting these kinds of symptomologies, you could be locked away in a hospital, and the hospitals effectively were prisons with chains on beds and everything. So I think we're fortunately really getting away from that kind of a modification. Healthcare, I think, has made some really good strides in this regard, especially in terms of insurance. I know not everybody is a big fan of Obamacare, and it's very political, but I'm just going to point out that one of the things that act did is that it did mandate coverage of mental health in insurance policies, which didn't really always exist before, and so that is increasing access of individuals to mental health. Again, not to get too political, but a lot of people have been talking with respect to, people that oppose gun control often say, well, it's not the guns, it's the mental illness, and I don't know if I don't want to go to that thing, but I think what it is pointing out is that people are more and more willing, increasingly, to think of mental illness as something that does need coverage by insurance, that does need our society's attention to help people that have these disorders, and not just sort of try to sweep them away, put them in prisons, or let them be homeless. So I think that's been a really positive development, and it's supported by what we've been talking about here in terms of neuroscience and the fact that we do have ideas about mechanisms that are underlying some of the disorders that people are experiencing. And I think we've seen similar changes related to addiction. The biggest addiction problem that we have currently right now is opioid addiction, which is largely addictions to pharmaceuticals that people were often prescribed by their doctors, at least to start, and that's what initiated it. And so now I think we're again starting to treat people that have addiction less as criminals and more as people that are patients that need help. And that again is supported, I think, well by the neuroscience behind them. All right, so we're going to get out of here early. I apologize for not fully giving you your $1 today. But on Monday, again, we'll do ideas, we'll do the homework, and then that's going to finish up our semester. I don't know if we'll need to meet on Wednesday or not, but we'll see.